Good evening, everybody. This is Dr. Nadeem, and we are today with our first session in cytopathology, that is Pursue 9A, and we are streaming live from Jodhpur, Kolkata. And today we have with us an expert who would be handling cytopathology. And I would like to introduce Dr. Poonam Abhay Elhence. She is MD, DNB, and she is a postdoctoral fellowship in cytopathology from PGI Chandigarh. She is a professor in pathology in All India Institute of Medical Sciences, Jodhpur. I would request Dr. Elhence to take over. Madam, please take over. Please share your screen. Dr. Elhence, can you hear me? Hello? Hello, Dr. Elhence? Hello? Yeah, Dr. Poonam Elhence, can you?
Hello?
Yeah, we can hear you. Yeah, can you just?
Yeah, but my screen share, yeah.
Yeah, just share your screen, please.
So I'm just going to log in, yeah.
No, you just be where you are, and from there,
Yeah.
you click on present now.
So I've done that, but it's not showing my presentation for some reason.
You just press present now.
So I've already done that.
Sorry.
I've already done that.
Okay. Then you just click on your taskbar. Click on your taskbar,
Yeah.
and you click on
Yes,
the
sir.
Chrome icon, and then you just press that Chrome icon,
Right, sir.
and it doesn't matter.
Sharing with some issue here.
Yeah,
Would like to, yeah.
it'll just take time. So no problem. Just it'll take some time. No issues.
Yeah, okay. Okay, sir. I'll possibly take a minute.
Doesn't matter. Doesn't matter. Take your time.
Okay.
You press present now, and then once you press present now, then you press sharing whole screen, your entire screen.
Right.
First you press present now, and then you press your entire screen,
Yes, sir, I've done that. I've done.
and
Yeah.
then you press on the taskbar at the Chrome icon, and then when you get
So I've done that too.
then it will say just present now. That's
Right.
we are waiting for your screen to come. Just a minute.
Yeah, sir, I'll just take a minute.
Doesn't
There's
matter.
some
Doesn't
issue
matter.
with the.
Doesn't matter. No issues. See, I'll just help you out. You just press present now.
Yeah.
Then you press your
So
entire
I've done
screen.
that.
You press your entire screen. Okay.
Yes.
And then you
Yes, sir.
press on the taskbar and you press share.
So I've already done all this. It'll just take me a minute. I don't know. There's something.
Doesn't matter.
So
Doesn't matter.
full screen. Okay. I'm trying. Give me 2 minutes more.
No problem. Take your time.
Exit full screen. Sir, I've mailed you the presentation. Can you open it for me?
Okay. You want me to open it? But
Yeah, that would be great because
no, you can comfortably do it. I mean, it is on your laptop, isn't it?
it's on my desktop. Yeah, and it's on my desktop.
Yeah. So you just don't worry. You just press. You are on Google Meet, so you just press present now, and then you press your entire screen.
Close. हेलो हेलो सर वो मैंने सब कुछ करके देखी है इट्स जस्ट नॉट वो स्क्रीन प्रेजेंट ही नहीं कर रहा आई डोंट नो व्हाई you see that you're presenting.
ओके नहीं नहीं, वो आप जो आपको मैंने कोड भेजा है ना, किस तरह से भेजा है? अच्छा मैं आपको मेल में भेज, मैं आपको मेल में। Yeah, just press on press now, present now, and then you will have the three options. You press your entire screen. And once you have that thing coming out, you just press on that white area, and then you press share. Yeah, Dr. Poonam, can you just unmute your mic first?
जी सर.
Yeah, just press on, you first say press on present now.
Done, sir. It says present your entire screen, a window or a Chrome tab.
Yeah, entire screen, press entire screen.
I've done that. Sir, I've been doing that for I think 10 odd minutes.
No, doesn't matter. After that, what are you seeing? Tell me.
It says share your entire screen and it says share and cancel. And only cancel is popping up. There is nothing to share.
Listen to me. You just press on that black area. There's a black area and the white area.
Yeah, I'm doing that. Yeah.
Press on that black area.
Done, sir.
The share thing will brighten up.
No, it's disappeared.
Can you see the share thing brightening up?
No, nothing.
No. When you are getting two options, share and cancel, isn't it?
So I did that. I said, I pressed on the black thing. Everything's vanished.
No. Just tap. Just tap on the black thing. Just give a small tap.
Yeah. Okay. I'll do that again. G.
Now the share thing will brighten up.
There's no share thing which is brightening up right now. Meeting, joining and nothing. Nothing. Even that's icon which was popping up, even that is gone off. I don't know how.
No, you press on
So,
on the Chrome in the taskbar.
yeah. Present now. See, hang हो गया है शायद, nothing is happening. Shall I log out and take a login again?
Yeah, you do that. Okay, doesn't matter. You start again. You press
Yeah, I
now.
can do that because I'll say, yeah, I'll start again. Okay, I'll say start again and then present now. Move ही नहीं हो रहा sir. I'll mic is off.
Yeah.
It says share. जी.
वो शेयर को दबाइए.
सर वो दबा दिया लेकिन उसके बाद कुछ नहीं दिखा था.
अच्छा, शेयर पहले शेयर ब्राइटन अप हुआ था, आपने इसको प्रेस किया था?
जी सर, शेयर ब्राइटन अप हुआ था, फिर उसके बाद इट जस्ट गोज बैक टू द सेम थिंग.
अब आप नीचे अपना पीपीटी आपका लेकिन आ नहीं रहा है स्क्रीन.
So I mailed you the PPT. If you can, present it from there, I'll keep on moving it. Because I think I've been logging in for the last 20 odd minutes.
Just a minute.
I don't know, it's not working. Thank you, Arshit. I don't know, it's not presenting. The dates have been fine. Please purchase minute. This is it, and he's constantly instructing me. Shall I do it from my laptop then?
Just a minute. Just hold on. Hello?
Hello, sir. Can you see the presentation?
I can see the present. No, you.
Hello, sir. Can you see the presentation? Yeah. So, very good evening, everybody.
We can't see your
And
presentation.
I apologize for the delay.
We can't see your presentation.
You can't see the presentation.
No.
Oh, okay. Okay, I'm logging in on the laptop now, sir.
Just a minute. Just stay where you are. I'm sharing your presentation.
Yeah, okay.
Just stay where you are. Just wait a minute.
You've got it out. Yeah.
I'm sharing
Yeah.
my presentation.
I don't know what it, sometimes it happens. It's happened today only with me. Because I've been trying for 20 odd minutes and there was nobody active. Hmm? And I was on time, but I don't give me. Thanks, God.
Yeah, hello? Dr. Poonam?
Yeah, hello, I can see the presentation, sir, right?
Yeah, please start.
Yeah, yes, sir. Yeah, thank you so much, sir. At the outset, I would like to thank Dr. Nadeem, sir, for giving me this presentation. I'm going to present on the Paris system for reporting urine cytopathology. So, hello, am I audible to everybody?
Yeah, clearly audible. Please go ahead.
Can I have the next slide, sir? Hello. Yeah, so before I begin, I would like to acknowledge Professor Eva Wojcik. She very generously allowed me to use her slides from the Paris classification, my colleagues at the Department of Pathology and the Department of Urology at AIIMS Jodhpur. Next slide, please. Before I come to the Paris classification, I would just like to tell you people about the history of urine analysis. So, urine analysis, according to the Journal of the Royal College of Physicians of Edinburgh, can be considered the first laboratory test documented in the history of medicine. So, you can see there is this lady standing with a round bottom flask and she's examining a pot of urine. That is how we started in the medieval ages. Next slide, please. Next slide, sir. So this is Ulrich Pinder's urine chart. There was something called the urine wheel, which had more than 20 odd colors of urine, with which they used to decipher the disease, and they would say the urine was ruby red, or it was, diseases associated with those conditions. So just an interesting anecdote here. When doctors were diagnosing with the urine wheel, taste and smell were considered as important as other characteristics, and a British physician has been known to saying the statement. He said that the patients who have diabetes, their urine tastes as sweet as honey. So other pictures to show the same. Urine analysis came to symbolize the medical profession, as we can see from these paintings by Trophime, and another painting in which Constantine is examining urine of African patients. So this is just to show you how we have evolved in urine analysis. So there is a Soloid Bragg urine test case from the Wellcome collection. They have these instruments. We have an S-Bax urinometer. We have these urine tubes, different jars to measure the urine physical and chemical properties. So just to give you an overview of how the urine analysis evolved. Next slide, please. So just to take an overview of the procedure, we get various types of urine samples, as everybody knows. But when we talk about the Paris classification, we will say that we have voided urine samples, catheterized samples, or bladder washes. These bladder washes are also called Barboutard specimens. For voided urine, not the first morning sample, that is not what is important. We need to examine the second midstream urine sample from patients, and this is the specimen of choice in males. Catheterized samples may be used in women. No fixatives are required if we are going to examine the specimens immediately. And if we anticipate a delay, the specimen may be refrigerated. So, next slide, please. Yeah. What are the various laboratory specimen preparation methods which are available? Cytocentrifugation, as all of us know. Membrane filter preparation, which are also called millipore, and there are several monolayer or liquid-based cytology preparations. In cytocentrifugation, we take small aliquots of urine, we centrifuge them and concentrate the cells and examine the sediment. So After staining them with special stains, liquid-based cytology, there are techniques like short path, thin path, in which Pathogenic staining is done. Before we go on to urine examination, as for the rest of pathology, it is mandatory to have a complete history, as history of instrumentation, prior chemo and radiotherapy. All these may result in cytomorphologic alterations, which may mimic malignancy. Now we'll come to the Paris system, which is abbreviated as TPS. So what is the goal of urine cytology? Why do we need this system? Why do we need to standardize? Why Paris? Why not Bethesda? What is the guiding principle with the same? I will just touch a little bit about the cellular elements in normal urine, types of urine specimens, what is the adequacy criteria for the same, the various diagnostic categories of TPS, and any adjuvant studies, if at all. Next slide, please. So why do we do urine cytology? It is very easily available, and you can take a random specimen, a voided second urine specimen. It's a non-invasive method of testing if we are talking about voided urine. It has the highest sensitivity and specificity for HGUC. Please keep this in mind. It has a high sensitivity and specificity for high-grade urothelial carcinoma. And in well-differentiated bladder cancers and other causes which result in atypia, it has a relative low sensitivity. Another thing which results in issues in urine cytology is that we can examine only a small fraction of the urine sample, and this reduces the chance of capturing the tumor cell sometimes. The background may confound the cytology. It may obscure. We might have obscuring RBCs, WBCs, etc. And we can have criteria which are ambiguous, as we all know. So next slide, please. So the main purpose of the Paris classification was to detect high-grade urothelial carcinoma. This is our main concern. And this is the chief goal, to detect high-grade urothelial carcinoma. So it is also used for follow-up in patients with a history of bladder cancer, for monitoring and surveillance of patients, including after therapy. Next slide, please. Why do we need a standardized terminology? As all of us know, that we started with Bethesda, right? So Bethesda classification for cervical cytology, then we moved on to Bethesda for thyroid, and we keep on updating them. So same for urine cytology. This is because we need that if I talk one language, somebody sitting elsewhere in the world needs to understand that. So improvement of communication and reproducibility. And these categories have corresponding management. The wide inter-observer variability, as we all know, and the range of this variability varies from 2% to 30% or even more when we talk about atypia. And we know that this is not unique to cytopathology. It applies to histopathology reporting as well. Next slide, please. Can I have the next slide, sir? Right. So if we need a reliable system, it has to be built based on evidence-based guidelines. It has to be inclusive, accepted by all. And if I say atypia, it has to be understood what I mean, right? So this is just to let you know that when we talk about things like the Paris, we are actually standing on the shoulders of giants. These are some images which I have borrowed from Memorial Sloan Kettering website. This is Leopold Koss. Anybody? So it's written here, Walinska, this is Papanicolaou, and these three people here are the cytotechnologists. This is Andrew Ritchie and this is Grace Durfee. This is Leopold Koss when he is much grayer and graceful, and this is Melamed, Myron Melamed. Next slide, please. Next slide, sir. So from there, standing on the shoulders of giants, we move on to Paris. And this is the idea of developing this Paris system came in a consensus meeting there was the International Academy of Cytology Congress, which was held in Paris in 2013 May. And they had these two symposias on urine cytology. Then they said, why not? There was a lot of head banging, and It came through after 3 years as the Paris system for reporting urinary cytology. Next slide, please. So the Paris system for urinary cytology has 3 chief people, and they are Dr. Dorothy Rosenthal from Johns Hopkins, Eva Wojcik from Loyola, and from Wisconsin we have Dr. Daniel. Next slide, please. So this is the outline. I would be presenting this under these headings. So what is the pathogenesis of urothelial carcinoma? This is quite important here. What is it? Then a few specific categories like negative for high-grade urothelial and so on and so forth. I'll come to these. Next slide, please. Okay, so coming to the pathogenesis of urothelial carcinoma, as all of us are aware, there are 2 distinct, well-established pathways, and these have risk-based prognostic categories. There is one which is called the hyperplasia pathway. Next slide, sir. Hyperplasia pathway, and the second is the dysplasia pathway. So as we all know, this is just, a recap. The hyperplasia pathway is more common. It's seen in about 80% of cases, and these are usually genetically stable. These cases start with urothelial hyperplasia and progress to low-grade urothelial cancer. In this, we have activating point mutations of FGFR3, which is nothing but fibroblast growth factor receptor 3. These usually have a non-aggressive behavior, though they are known to recur. Next slide, please. Then we come to the dysplasia pathway, which is less frequent, usually seen in about 15 to 20% of urothelial carcinomas, and they are known to be genetically unstable. They are associated with inactivating mutations of P53 protein, and these start with dysplasia, and they are known to have higher grades of tumors, including muscle-invasive bladder cancers. So what is the new paradigm? As I've repeatedly am saying, please remember the thyroid, the TPS, that is the Paris classification, just like Bethesda and others, is about high-grade urothelial carcinoma. Please remember, if we remember this, we will not go wrong. There is a category called negative for high-grade urothelial carcinoma, and these are the other categories. So we have atypical urothelial cells, we have suspicious for high-grade urothelial carcinoma, and we have high-grade urothelial carcinoma. These are separated by quantity, and these are separated by both qualitative and quantitative nature of the material examined. And a new category has been introduced, which is LGUN, low-grade urothelial neoplasm. Next slide, please. So when we talk about the guiding principle, again, repetitively, this is for the postgraduates, we want to detect and not miss any high-grade urothelial carcinomas. Negative category. So negative for high-grade urothelial carcinoma means all those categories in which we say we can attribute it to a particular condition like reactive changes, viral, and features of low-grade urothelial neoplasia. So we say these are negative. That is the second category. And there are some cases, we will not use it as a waste basket diagnosis because we definitely have criteria. So these are those cases where a definitive diagnosis sitting on the fence, that is not the goal of this. So we say atypical urothelial cell. Can anybody text what is the, it doesn't matter. So what is the guiding principle for the Paris system? The difference between suspicious for high grade and high grade is quantitative, as the diagnostic features are quite similar. So the number of cells allow you to definitely say whether it is high grade or just suspicious for high grade. And this new terminology called low-grade urothelial neoplasia is based only on the presence of well-defined fibrovascular cores. So we have these 3-dimensional fragments with very well-defined fibrovascular cores. Until and unless you do not you see these fibrovascular cores, you cannot call it LGON. Right. So as you know, urine is a heterogeneous mixture of several particulates, and these are namely urothelial cells, squamous epithelial cells. Some cells may come in from the prostate, some anal vesicle. You might have renal tubular epithelial cells, crystals, inflammatory cells, and cells from the neobladder or the ileal conduit. Next slide, please. So just a few, as we've already covered this, what are the types of urinary specimens we get? We get voided urine, catheterized urine, washings from the cystoscopy. This is called barbotage. Upper urinary tract washings when we put in a ureteroscope, and ileal conduit or neobladder specimens. Next slide, please. So how do we decide adequacy of the urine specimens for the diagnosis of urothelial carcinoma? As we, similar to Bethesda for thyroid and cervix, this is determined by the interplay of 4 specimen characteristics, which are the collection type, whether it is catheterized or voided, the cellularity, what is the volume, and the cytomorphologic findings. Next slide, please. So, when we talk about cytomorphology, next slide, please, we should remember that these findings should be considered first and foremost. Just like the Bethesda cervical cytology, presence of any atypical or suspicious or clear-cut malignant findings makes a specimen adequate, regardless of its cellularity, the specimen type, the volume of urine received in the laboratory. So when there are no findings indicative of such a disease process, other factors will come into play, like, as we all know, in a voided urine sample, they say a sample which is more than 30 milliliter in volume is more likely to be adequate. And similarly, when we instrument, that means in catheterized samples, we should have about 2 urothelial cells per 10 high power field. So this is about the adequacy of the urine specimens. Next slide, please. So just highlighting the same, this is an algorithm which says that if you have atypical, suspicious or malignant cells, it automatically becomes an adequate sample. Then if you have an instrumented sample, if you have appropriate benign urothelial cellularity, it becomes adequate. And if you don't have it, that is, if you don't have 2 urothelial cells per 10 HPF, or you have less than 2600 cells, it becomes inadequate. Similar for adequate volume. If the volume is not adequate and you don't get adequate cellularity, so you say it is inadequate. So this is just an algorithm of the adequacy of the urothelial carcinoma urine. Next slide, please. Right, so we come to the first category of the Paris classification, which is negative for high-grade urothelial carcinoma. Please remember, this will include all entities which pose no significant risk to the patient. No significant risk to the patient for developing an AGUC. This is based upon several studies. So they say negative for high-grade urothelial carcinoma poses no significant risk. If you find a specific cause for a morphologic alteration in the urothelial cells, please mention negative for AGUC and don't write atypical. And these are called benign cytologic changes. For this category, we can use ancillary tests to confirm a causative agent if there is no corresponding history available. Next slide, please. So how do you define? They've given definition for all categories. So what is the definition for NHGUC? This year sample of urine may be considered benign or negative for high-grade urothelial carcinoma if any of the following components are present. And what are these components? You may have benign urothelial, glandular and squamous cells. You may have benign BUTF, that is a benign urothelial tissue fragment, and sheets or clusters, especially if it is an instrumented urine. Changes associated with lithiasis, these can they can mimic malignancies. They are responsible for those AUS category. They used to be viral cytopathic effect. All of us know about polyoma virus, usually BK/JC virus rarely, and post-therapy effect including epithelial cells from urinary diversion in case of cystectomy patients. Next slide, please. Okay, yeah. Thank you, sir. So the other, I've already told you we can have viral cytopathic effect. Unless and until they are accompanied by atypical cells, they fall into NGHUC category. Yeah. NHGUC, and post-treatment effect for non-bladder disease. Unexpected normal cells like cells from the endometrium, from the seminal vesicles may confound the problem further, but these have to be labeled as as negative for high-grade urothelial carcinoma. I apologize for this. Next slide, please. Yeah, so just a few images to show you. It's pixelating for some reason. Yeah, it's okay now. So this is just to show you the urinary calculi. And this is, if you can make out, these are borrowed from Dr. Eva's slide. So this is, a specimen of a slide from a seminal vesicle. So you can see the yellowish lipofascian pigment. This is a renal tubular epithelial cast. And these are some glandular cells possibly. This is from a male. These are, you can see some umbrella cells here. So these are possibly some benign glandular cell. They could not ascertain the origin. Next slide, please. Right. So I'm sure everybody can make out, just look at these elongated bacteria, some polymorphs here. These are yeast forms of Candida. Anybody? What are these round red inclusions in this degenerated urothelial cell? You can type out your answer. Next slide, please. I've shown you two of the people who were responsible for naming these lesions. These are nothing but Melamed-Wolinska bodies in degenerated urothelial cells. We come to the next category in the benign cytologic findings, that is the BUTA for the benign urothelial tissue fragments seen in instrumented urine. So please remember, these will lack the true fibrovascular cores. They do not have fibrovascular cores, and therefore these are true tissue fragments. Typing them further depends on their nuclear and architectural details. So we say if these are benign, we say these are BUTF. You can call this as that is negative for high-grade urothelial cancer, and you can say BUTF. Yeah, benign urothelial tissue fragments, or you can. So this is one more category, and these can be seen in, as I've already told you, in instrumentation, in lithiasis of the urinary tract, and usually in the renal pelvis. Next slide, please. Right. So again, I'm reiterating, urolithiasis is one of the most significant pitfalls in urinary cytopathology. And the clinical history is crucial, which we often do not get. And these cells can look quite ugly, and leading to an overdiagnosis of atypia or, like suspicious. So, urothelial, and we all know that urothelial carcinoma and squamous cell carcinoma have been associated with both renal calculi or infection. Next slide, please. Few other changes which occur in the category of negative for high-grade urothelials. Just an interesting thing that both BK and rarely the JC virus, they take this abbreviation which they were first identified. And we know that polyoma viruses are double-stranded, non-enveloped viruses, and they have a single homogeneous basophilic inclusion. These are often called decoy cells. Next slide, please. Next slide, please. Yeah. So where did it get this name decoy? So there were these decoy ducks used in USA for hunting wild ducks. When the ducks would see, they thought these are real ducks floating, they would come and they would be captured. So the first picture that I showed, Andrew Ritchie was a cytotechnologist working in the cytology laboratory at Memorial Sloan Kettering, and he gave this name of decoy cells. So a duck decoy is a man-made duck carved from wood, cork, plastic maybe, resembling a real duck, used to attract. Next slide, please. So we are still continuing with category 1 in the Paris, that is negative for high-grade urothelial cancer. They say urothelial changes which can be attributed to treatment effects, whether it's radiation, BCG immune therapy, or chemotherapy, mitomycin, thiotepa. All these should be categorized not as atypical, but as negative for high-grade urothelial cancer. And so as we all know, just like other systems, we have cytomegaly, we have neoplasm, multinucleation, we get vacuolation in the cytoplasm and the nucleus, and no overt features of malignancy. We should have this history. We usually do have history of radiotherapy, chemotherapy, and even immune therapy. So please remember, this should not be called as atypia. It should be or suspicious. They should be called as negative for high-grade urothelial cancer. And as we know, bacillus-guerin, the immune therapy can cause granulomatous inflammation. Next slide, please. Right. So now we come to the second category, which is the one which is causing a lot of problems. It causes pathologists to sit on the fence on their diagnosis, use it as a wastebasket terminology, just like other classification systems. This is called atypical urothelial cells, or AUC. So please remember, it has a strict definition, including urothelial cells with mild to moderate cytologic atypia. It does not include the tissue fragments without cytologic atypia. And these changes have to fall short of the diagnosis of suspicious for high grade or high grade. So next slide, please. Yeah. Next slide, please. So the definition is that we need one major criterion and one minor criterion to diagnose AUC. What is this major criterion? The major criterion says that you should have a non-degenerated urothelial cell or a non-superficial urothelial cell with an increased NC ratio. Now, what is this increased NC ratio? They say the nucleus should be occupying more than 50% of the cytoplasm. That is, the NC ratio is more than 0.5. And only one minor criterion out of 3 should be present. And what are those 3 minor criterion? You should either have nuclear hyperchromasia. And when do you call something hyperchromatic? You need to compare it with a normal cell. And what is this normal cell? It is a normal umbrella cell or the nucleus of an intermediate squamous epithelial cell. The second minor criterion is irregular nuclear membrane. Rather than being smooth, it is irregularly contoured. And the chromatin is irregular, coarse and clumped. Please remember, there should be one major criterion and only one minor criterion to call something AU. Next slide, please. Next slide, please. Sir, can I have the next slide, please? Sir, can I have the next slide, please? Sir, can I have the...
Not changing. Just 1 second.
Oh, okay. No issues, sir.
I can see the slide, but I can...
Yeah, I can't see. It doesn't matter. I mean, the others can't see it. Otherwise, to me, it is...
Just hold on.
Yes, issues. There are some issues. I can teach with, I can go on if you want without...
Just a minute. Let me just check something.
Sure, sir. I can see the next slide. It's not on a slide view though. If you want, I can go on from here. There's no issue.
Can you see now?
Yeah, I can see. I don't know if the others can see. I can't see your slides.
It's available. Just go ahead.
Everybody can see, right? Sure. So, can I have the next slide, please. It's stuck on this. Yeah. Can I have the slide? Okay. Thank you, sir. So, as I told you, when we talk about atypical urothelial cells, the slide before this, sir, when we talk about atypical urothelial cells, we have to remember that both the quality and the quantity is important for diagnosis. Next slide, please. So there are certain factors which obscure the urine cytology, and you know these factors might be blood, there might be inflammatory cells, there might be a poor cellular preservation or degeneration. So in this case, please do not try to give a definitive category. You can just say inadequate or unsatisfactory. It's better to be prudent rather than to be sorry later. So please remember, there are some times when you cannot say definitely that it's AUC or something. Please carry on and say that it is inadequate or unsatisfactory. Now, there is another caveat to this. Where there is a suspicion for high-grade urothelial carcinoma, but there is a lot of degeneration, the valid choice of category would be AUC. Better to for the clinician to repeat the urine sample for the patient, maybe cystoscopically, maybe with a barbotage, but with extensive degeneration, straight away do not call AGUC. And they will not definitely categorize the number of cells which are required for atypical urothelial cells, but some studies showed that those atypical urothelial cells which went on to have a negative outcome, had an average of less than 9 atypical urothelial cells, had a positive outcome in terms of malignancy. They showed that there were more than 16 atypical urothelial cells present. So next slide, please. Right, this is just to show you that this was a specimen of degenerated urothelial cells. We cannot really make out the nuclear details, they are not very crisp. And this is something that they would call atypia of atypical urothelial cells. As we said, see, so this nucleus is much larger. These are some prominent nucleoli, but the ratio is maintained. It is not really more than 0.5 in all of them. Right. So these are some examples where you just, this was a degenerated urine. So just, we should lower our rate of atypical urothelial cells. Why? To gain credibility. Please do not use it as a wastebasket terminology. I'm reiterating. Across institutes, the reporting rate of atypia ranges from as low as 2 to 31%. Despite the efforts to define this entity narrowly, like we said, one major criterion, one minor criterion, it has only fair reproducibility. And for it to be credible, the frequency has to be minimized. We should not call anything and everything atypical urothelial cells. I've already told you that if there is something which can be attributed to a definite category, whether it is viral, cytopathic, treatment related, we should say negative for high-grade urothelial cancer. So as more evidence-based data becomes available, recommendations of the frequency of AUC interpretation will evolve further. So this is just to tell that the risk of detecting a biopsy-proven AGUC following an AUC diagnosis ranges anywhere between 3 to 34%. The next category is suspicious for high-grade urothelial cancer. So there in atypical urothelial, we had one definite and one minor criterion. Please remember, here we have 2 required criterion and one of the following minor criterion needs to be present. So there the ratio was 0.5. Here they have said the increased NC ratio at least 0.5 to 0.7. So this is a required diagnostic criterion, the other being moderate to severe hyperchromasia. At least one of the 2 following features needs to be present. This is in the minor criterion. You should have irregular clumped or clumpy chromatin and markedly irregular nuclear membranes. There should be no smooth contouring of the nuclear membranes. So instead of having one definite, we have 2 definite here. As I've already told you, the quantity matters. When we move from AUC to NGHUC to AGUC, the quantity matters. Just see, these are some relatively okay looking low nuclear cytoplasmic ratio, and we have these 4 cells here. So you can see hyperchromasia, moderate to mild hyperchromasia, nuclear membrane irregularity, and you can see that this is high NC ratio. It is definitely more than 50% of the cell area is occupied by the nucleus, right? But they have said that if you have only these less than 5 to 10 cells in a urine sample, please don't straight away say AGUC. Say it is suspicious for high-grade urothelial cancer. Please remember, quantity matters. Less than 10 cells of these kinds in a urine sample, please call it suspicious for high-grade urothelial cancer. A cutoff range of 5 to 10 cells is recommended based on the degree of abnormal nuclear changes and the level of pathologist comfort. This is a nice word that they've written here. They've written depends on the experience and the level of pathologist comfort. So a positive for HGUC or a high-grade urothelial cancer diagnosis should very rarely, if ever, be given in the presence of less than 5 abnormal, well-preserved cells. Please remember, quantity matters. So for something to be HGUC, please be comfortable with more than 10 cells. In the presence of 5 to 10 abnormal cells, we should preferably call it suspicious for high-grade urothelial cancer. Next slide, please. Right. So, as we know, this is all done by visual inspection. This can be very subjective. So, everything else also needs to be taken into account, this being the type of the specimen, whether it is voided, whether it is barbotage, catheterized, the clinical history of the patient, the degree of atypia uniformly across the cells. It should be that 1 or 2 cells and then you say it is SHGUC, right? So it is recommended to have at least one of the abnormal cells in the specimen show all the features which were written. Next slide, please. All of this is done by eyeballing. There is no measurement here. So Zhang et al., they've given a visual analog sort of a thing and they've said this is the NC ratio when they say suspicious for high-grade urothelial carcinoma. So 0.5, more than 0.5 to 0.7, right? Just look at this. So 0.4 here, 0.5. So more than 0.5, we said it was AUC or atypia of atypia in urothelial cells. When we come to 0.7, that is more than 70% of the cellular area is occupied by the nucleus, we are moving to the high-grade categories. Next slide, please. So we usually do this by eyeballing. We are not measuring the nuclear diameter. We come to the most important category of Paris classification, which is the AGUC. That is the high-grade urothelial cancer. Cellularity, I've already told you, at least 5 to 10 abnormal cells. Anybody will testify that these are really abnormal looking. The NC ratio needs to be more than 0.7. And the nucleus, just look at the chromatin here. It's very hyperchromatic, very dark. Compare it to any nucleus. The nuclear membrane does show some irregularities. The chromatin is coarse and clumped. Next slide, please. So, please remember, AGUC, the chief goal of the Paris classification is, next slide please, the chief goal of the Paris classification is to say whether something is high-grade urothelial cancer. Just look at this. You can see some necrotic debris clinging to the cells, some polymorphs here. So, just like other criteria for malignancy will come into play here, marked variation in isonucleosis, varying type of cytoplasm, prominence of nucleoli, atypical mitoses, necrotic debris, and inflammation. Next slide, please. Next slide, please. So there is something called the anticipatory positive phenomenon that shows that if we are following those cases we've called positive, and the period of the period that we follow them for is relatively less, let's say less than 6 months, and we do not discover a malignancy, it tends to underestimate the true specificity and positive predictive value of urine. So we have to realize that this has to be followed. These patients need to be followed for a longer period, and this will lead to the discovery of even occult urothelial malignancy, this which is well known. And this has a very high malignant association. A positive urine cytology will be followed clinically by cystoscopy, biopsies, and additional assessment of even the upper urinary tract if we don't find something in the urinary bladder per se. The other category, they have, so initially we used to say low-grade urothelial carcinoma. They've done away with this and they've replaced it with LGUN, that is low-grade urothelial neoplasm. So this is a three-dimensional cluster. And they say it's, it's paradoxical in pathology that in nowhere else in the system do we say carcinoma if it has not gone beyond the basement membrane. But in urothelium, we say that. So is it truly a carcinoma? And this is not life-threatening. Next slide, please. So they've changed it and they've called it low-grade urothelial neoplasm. And they say that these are three-dimensional fragments which should have a definite fibrovascular core. So look at this beautiful papillary fragment and you see a fibrovascular core here. So this is what they have chosen to call LGUN. And they have used this term for all the low-grade lesions like a urothelial papilloma, for pun lump and low-grade papillary urothelial carcinoma. I've already told you this, three-dimensional cellular papillary clusters, and they show nuclear overlapping. The most important is a nice fibrovascular core with capillaries should be seen in this to call it an LGUN. It's a definite category. So they have summarized all these categories and they've said, first of all, you see whether the cytologic atypia is present. If it is present, what is the degree of atypia? Is it mild? It is moderate to severe? Then you go on to the NC ratio by eyeballing method. And you see whether there are other minor criterions present, which may be hyperchromasia, nuclear contour irregularity, that is the nuclear membrane irregularity, and you see whether the chromatin is coarse or not, right? If you can say that there is mild atypia, there are reasons for mild atypia. Like we said, lithiasis might be there might be some viral cytopathic effects, there might be treatment related. So then you call it negative for high-grade urothelial carcinoma. And if you don't have a reason for this mild atypia, you have no history, you can go on to call it AUC or atypia in urothelial cells. And when we come to the severe atypia, as I've already told you, it's the quantity of atypical cells which matters. If the number of abnormal cells is less than 5 to 10, please refrain from calling it a AGUC. You can call it a suspicious for high-grade urothelial carcinoma. Actually, clinicians will treat both of them the same way. So it really doesn't matter, but just for the reporting point of view, if it is below 5 to 10 cells, go on to call it suspicious. If it is more than 10 cells and abnormalities are seen across, please call it a positive for high-grade urothelial cancer. Next slide, please. Right. Other malignancies are known to occur in the urinary tract. They may be primary and they may be secondary. Primary malignancies, you may get adenocarcinoma, squamous cell carcinoma, small cell carcinomas. And for secondary neoplasms, we can have prostatic carcinomas, colon carcinomas going into the urinary bladder, renal cell carcinoma shedding into the urine. Next slide, please. So are there some ancillary studies in urinary cytology? Yes, I'm sure all of us know it by now. We have often heard in some of our doing it. We are not doing this currently in our department, but everybody knows about Eurovision. It's a multi-probe test, and SEP3, SEP7 and SEP17, we all know these are centromeric enumeration probes for the alpha satellite regions. This is a locus identifier. So this tests for all these it's multi-probe assay. So please remember, we have Eurovision for those cases which we call atypical urothelial cells. Next slide, please. So this this is just to tell you that these are relatively specific for molecular alterations in bladder cancer, and these avoid confounding effects of RBCs and inflammatory cells. But it also has a other side to it, that you BK polyoma virus and some other, if you don't have such histories, they may light up on fish. I've already told you, negative for high-grade urothelial cancer, not required in high-grade urothelial cancer. Where does it have a role to play? The moment you say atypical urothelial cells. And this, as I've told you, has a wide range of reporting, actually from 2 to 30%. Next slide, please. Next slide, please. Yeah. So what is the ultimate, why do we want to categorize all this? Everything should have a clinical implication. If I say unsatisfactory or non-diagnostic, what is the risk of malignancy that I'm looking at? Or if I say high-grade urothelial cancer, just like the Bethesda for thyroid, if we say a non-diagnostic or unsatisfactory, if we say negative, it has certain risk of malignancy associated. So when we come to, let's say, the atypical category, the risk of malignancy is 8 to 35%. And then there is a management protocol with all these patients. So there is no problem when we come to suspicious for high-grade and high-grade urothelial cancer. These patients will be aggressively followed up. They are subjected to a cystoscopy. They do a TURBT or a biopsy depending on the stage at which the patient is presented, and then these are sent. Remember, for all the whole exercises, because all these categories have a certain risk of malignancy associated and leading to further management and for the patient. So just remember, negative, the moment you say something is negative, the patient is clinically followed up until and unless the patient is not improving clinically, comes back with gross hematuria, and the clinician feels that there is a need to repeat. Next slide, please. Yeah, just a few images from the cases that we report. So can anybody type out what is this? Can anybody speak out or type out what is this?
If you can unmute your mic.
I can't hear you. So excellent, Kurat. So Kurat says it is actually a granuloma, but there was something interesting in this patient. He was about 56 or 57-year-old male, neutrophils in the background. We had no history whatsoever of intravesical BCG installation. We did ZN staining, as we know, ZEAL modified ZN staining, and we saw a lot of elongated acid-fast bacilli. We went back to the clinician. We said, can this patient be worked up for immune suppression? And we were not surprised when he turned out to be immunosuppressed, and he tested positive for HIV, reactive for HIV. So we had, please remember, the source of a granuloma necessarily in urine may not be only intravesical BCG installation. We definitely need to keep other things in mind, however uncommon they may be. Next slide, please. This is not coming up very well, but these were elongated acid-fast positive bacilli. Again, a slide to show you a degenerated urothelial cell. If you can see these beautiful red inclusion-like round bodies in the cytoplasm usually. These are nothing but, anybody? I've already said what these are. These are Melamed Wolinska bodies. So Melamed was a pathologist and Wolinska was a cytotechnologist. So Myron Melamed is no more. And just some elongated bacterial strands. These are yeast forms or spore forms of Candida, neutrophilic infiltration. These are what we call, what are these called? These we say are NHGUC, that is negative for high-grade urothelial cancer. And this we said, we call this benign tissue fragment. We call this a benign tissue fragment, but this turned out to be something else. This was from a voided urine. These were infrequent. Some neutrophils, a lot of blood in the background. So I'll just show you what this turned out to be. Can I have the next slide, please? Right. So another picture to show you, this is the same slide with the degenerated urothelial cell, a beautiful melamed Wolenska body. Another urine specimen with a lot of neutrophils in the background. We are not doing liquid-based cytology. These are the slides which are prior to the, we have now gone back and we are trying to classify our urothelial carcinoma slides on the basis of the Paris classification, but this is prior to that. So just look at these large clusters. Some of them contain 8 to 10 cells. They are loosely cohesive. They have high NC ratio. So we call this positive for high-grade urothelial cancer. I'll just show you the next slide and let you know why. We had some parakeratosis. Yeah, so more images from the same case. Nobody will dispute what is this. Can you type in? Can you people type in what you think it is? So this is what we would call a tadpole cell. We've done, yes, thank you, Shovik, Kurat, Nusrat, Sudhar, thank you, fiber cell or tadpole cell. So you can see that the, just look at this. So keratinized cells with markedly hyperchromatic nucleus, which is irregular, look at it here, and for comparison, a nice, neat squamous epithelial cell here. So we said this was possibly high-grade urothelial carcinoma with squamous differentiation, which is known to occur in about 25% of the urothelial cancers. Next slide, please. So this is we received TORBT for this. Images are pixelating, but when we receive the TORBT, you can see that there is squamous metaplasia of the overlying urothelium, going much deep into the lamina propria, gone beyond the lamina propria. This was the deep muscle in the TORBT, that is the transurethral resection of the bladder tumor. We can see some squamousness going deep into the muscularis propria. We can see a lot of keratinization, some keratin pearls here. So this actually turned out to be high-grade urothelial cancer with squamous metaplasia and extensive squamous differentiation. Next slide, please. Right. So another case, this, now that we go back, we just call these cells as atypical. We call them atypical to suspicious. We were sitting on the fence because it had a lot of neutrophilic infiltration. There were these loosely cohesive cells, did not have a lot of hyperchromasia, but some of them showed about 70% ratio between the nucleus and the cytoplasm. So, but not much hyperchromasia. We just said atypical, and this is what it turned out to be. We had urothelium, and again we had squamous differentiation of the urothelial cancer. So we missed this one. This is just to show you that these are those cases which cause a lot of problem. Yeah, next slide. So another Papanicolau stain smear to show you a bizarre multinucleated cell. It has about 6 to 7 nucleus suspicious. Similar picture here. We call this high-grade urothelial cancer because very abnormal looking cells, some of which multinucleated, had high NC ratio. Next slide, please. We have, so this is for the time. You can type out your answer, I'm okay with that. So we have a cell with a high NC ratio. Yes, absolutely, Nusrat, absolutely right. It is a decoy cell, Preeti. Yes, this was a case. She's a post-renal transplant recipient, and so the urine showed nice decoy centronuclear basophilic inclusion, and this is a short tail, almost looking like a comet. So these are also called comet tail cells or decoy cells. Next slide, please. Next slide, please. Yeah. So this is the case I showed you in which this is an HME stain slide, and We can see, we call this benign urothelial tissue fragment. There was no fibrovascular core, and there were just only occasional fragments with these community borders, what we call papilloid. But there was no fibrovascular core even on going back. And this is what we got on histopathology. We had a very well-oriented, not very markedly dysplastic looking cells, but going quite deep into the lamina and maintaining its attachment with the urothelium above. So this is the urothelium, this is the edematous lamina propria, and a tumor which is actually going quite deep into the lamina propria. So this is what we undercalled on cytology, because we didn't see any fibrovascular cores, we didn't see much atypia, which is also seen in the corresponding histopathology section here. Next slide, please. Yeah. So this was another case which came in urinary cytology. Very crazy looking cells, very high NC ratio, some sort of a molding or a windowing or whatever you want to call it. Very neatly packed with each other. I would rather call it molding than anything else, right? Very high NC ratio. This is pixelating, not showing here, but very hyperchromatic, as you can see here on the HE, on the Pepanicola stain here. Very high NC ratio, very hyperchromatic, right? Next slide, please. I want to show you the histology for this. Though the markers for neuroendocrine differentiation did not help, but on the histology also we got tumor and DT for this patient, and as you can see, it's a very cellular neoplasm, very cellular, and cells with high NC ratio, even at this power, which is pixelating, and extensive necrosis in between a few ectatic capillaries here and there, right? What else you would call it? What else? What would you call it on, let's say if you're seeing this from the lung, what would you call it? You can type, yes, small cell variant, yeah, correct, yeah. But, you know, I mean, for us, as the WHO 2016 says that you don't really need to prove this by IHC markers. If you see it on morphology, that is what we called it. We said it was a carcinoma with a neuroendocrine differentiation. Next slide, please. So that is the penultimate slide of the session today. So what is the take-home message from all this? Please don't get disheartened by the AUC category or on missing cases. It is our, it is a learning ladder for us. The ultimate goal of the Paris classification is high-grade urothelial carcinoma period. This is the only one that matters because it behaves very aggressively and it needs to be treated aggressively. The criteria, as I've already told you, negative for high-grade urothelial cancer includes all those categories which you can name. You may have atypia due to stones, atypia due to viral inclusions, due to treatment effects. Please call them negative for high-grade urothelial carcinoma and you can classify it further. The diagnosis atypia, please do not use it to sit on the fence or as a wastebasket diagnostic terminology. There are well-defined criteria. We've already covered this, one required and one minor criterion. Try to fit it into that. If it doesn't happen, then we sometimes do get those problems. They've introduced a new diagnostic category, which is LGUN, that is low-grade urothelial neoplasia, for which we definitely need a beautiful fibrovascular core in a 3D fragment. Urinary cytology cannot distinguish high-grade urothelial cancer or carcinoma in situ, which is well known to all of us. Not all malignant cells in urine may be from the urothelial carcinoma. They may be, as we've seen, from other secondary malignancies or the UTUC. Future studies are needed for validation of the Paris classification. So this, I just want to bring it to your attention that there is a site on Twitter for reporting where the American Society for Cytopathology and the International Academy, they are working together on the second edition of the Paris system. And there is an online survey for the same. So if we have queries, if we want to be heard, I would say please participate in this survey. Give your comments, go online to the Twitter site, give your comments. Maybe our concerns can be addressed in this. Unless we participate, our concerns will not be heard. Next slide, please. So thank you very much for patient hearing. And thank you to one and all. Thank you, Nadeem sir, for letting me be a part of this. And I'm happy to answer any queries. Kurat, you had asked that why didn't we call it, why can't we call it squamous cell carcinoma? We could have called it squamous cell carcinoma, but it did show some areas which are typical urothelial cancer. So we prefer to call it urothelial carcinoma with squamous differentiation. Entirely, it wasn't like a pure squamous cell carcinoma. Any questions? Any queries?
You can unmute your mic and ask a question directly to madam.
So, I apologize for one or two spell errors. I think I'll go back and correct them. I didn't realize while I was typing it out.
It was a wonderful presentation.
If no questions.
Very different questions. The last case, HGUC, which you said with neuroendocrine differentiation, was it called so without any supporting evidence? This is
right.
Question there.
So actually, on cytology, we just said it's a high-grade urothelial cancer. And when it came on histopathology, we said it's a high-grade urothelial cancer with neuroendocrine differentiation. But when we did the markers subsequently, they didn't light up. So then we went back to WHO, which says in 2016 that you don't really need to validate it with markers. You can straight away say that it's neuroendocrine because it looked like small cell cancer, which occurs in lung, similar. But even poorly differentiated urothelial cancer may look like that. But our markers didn't work for this case, so they didn't help. Yeah. Even in cytology, it showed this molding, very high NC ratio, hyperchromasia. I'm not sure we saw mitoses, I can't recollect, but this is what it showed in cytology. Yeah.
Fine, thank you, Dr. Poonam, for such a wonderful presentation. Very nicely put up, and I think the presentation is clear. Thank you so much. Thank you everybody for participating. Thank you so much, and I think we will.
Thank you, sir.
We will catch you again for something new. Right? Okay, then take care.
Thank you so much, sir.
Take care. Bye.
Thank you, sir.